today's speaker.
All right, welcome everybody. Aivi Nguyen is a practicing neuropathologist and translational neuropathology researcher with a special focus in neurodegenerative diseases. She completed her combined residency and fellowship training in anatomic pathology and neuropathology at the Hospital of the University of Pennsylvania and pursued postdoctoral training in the Translational Neuropathology Research Laboratory at UPenn as well, under the mentorship of Dr. Eddie Lee. Dr. Nguyen is an actively contributing neuropathologist to the Mayo Clinic's Alzheimer's Disease Research Center and Mayo Clinic's Study of Aging, both of which involve the study and characterization of aging individuals over time by integrating multidisciplinary efforts. She's a recent NIA KO8 recipient for the project titled Role of Microglial Heterogeneity on Cognitive Resilience in Aging and Alzheimer's Disease. Her primary research interest includes the role of neuroinflammation and glial cells, specifically microglia, in normal aging, cognition, and neurodegeneration. And today she's going to talk to us about the practical approach and evaluation of common neurodegenerative diseases. Thank you, Aivi, for coming, and take it away.
Good morning or good afternoon, everyone, depending on where your time zone is. Thank you so much for tuning in, and thank you very much, Maria, for the very kind introduction. Many appreciation and thanks to the AANP Teaching Committee for inviting me for this talk and allowing me the platform to share a little bit about what we do at Mayo Clinic in the aging, basically the ADRC and the Mayo Clinic Study of Aging. So today the talk is titled, as Maria mentioned, The Practical Approach and Evaluation of Common Neurodegenerative Diseases, but I really wanted to make this more of a case-based learning. I know that Dr. Eddie Lee a couple years ago had given a very beautiful talk setting the foundation for approaching Alzheimer's disease and comorbidities or common comorbidities. And I thought this would be a really nice, this would dovetail really nicely into this talk and be almost like the application of some of the foundational things that he had laid down in his first talk. So think of this as almost like part 2 to neurodegeneration. And if you have time, I would highly recommend going back into the archives and watching his lecture and then watching this in conjunction. So you'll see a little bit of callback to his slides as well. But again, I wanted to emphasize that this is a case-based learning environment, very informal as well. So please feel free to ask as many questions as possible. Hopefully I can answer some of them. Yeah, I think that's it. Hopefully this will just be a nice way to approach different cases, whether it's in a research setting or in the common autopsy setting. So the learning objectives for today are to build a differential diagnosis of neurodegenerative diseases based upon gross pathologic findings. 2 is to identify key histologic sections used to diagnose Alzheimer's disease neuropathologic change, or ADNC, and the common comorbidities. 3 is to apply harmonized criteria to diagnose ADNC in other neurodegenerative diseases. They won't just be common comorbidities, but there'll be a few more exotic cases thrown in there just to show kind of the spectrum of neurodegeneration. So taking a very large step back, dementia is essentially a progressive and irreversible syndrome that affects multiple cognitive domains and results in impaired activities of daily living. And so oftentimes we think of dementia as being an amnestic issue, but actually because it involves multiple cognitive domains, it can present as either progressive memory dysfunction, stepwise neurologic decline, behavioral personality changes, language dysfunction, or movement disorder. A lot of these clinical presentations and clinical symptomatology has underlying neuropathologic features, such as for progressive memory dysfunction, we often will see beta amyloid plaques, neurofibrillary tangles, such as in Alzheimer's disease. When patients sometimes present with stepwise neurologic decline, there could be an underlying vascular mediated brain injury. And if there are behavioral personality changes or language dysfunction, the underlying pathology is oftentimes TDP-43 or tau. Last but not least, for different movement disorders, the underlying pathology can be Lewy bodies or Lewy neurites. So this is just to show you the spectrum of how dementia can present and how it can affect multiple domains. One thing I do want to mention is that in terms of the neurodegenerative disease overview, and this table lays out basically the diseases in column A, and then the different types of neuropathologic lesions we might expect to see in column B. And last but not least, in column C are the components or the protein blocks that create those pathologic deposits in the brain. The way I think about neurodegeneration and the approach to neurodegenerative disease cases is we're really trying to evaluate the spread and the severity of these different types of pathologies. And then eventually, in a separate area, we try to marry the clinical symptomatology with the neuropathology. But our job as a neuropathologist really is to look at the gross, the micro, and come together and show the lesions and the different components. So again, just documenting spread and severity of these proteinopathies. So as I mentioned, this is a case-based learning environment. So we'll start with case number 1. So this is a case of a patient with a 60-year-old female who died with a 7-year history of cognitive impairment and motor deficits. There's no pertinent family history or additional family history there. She first presented with sporadic jerks, REM sleep disorder, and then developed cognitive changes a few months afterwards. Her physical exam showed asymmetric rigidity in arms and a slowed gait, and brain scans were performed, and eventually she demonstrated worsening cognitive impairment, and she then died at home. So the approach here is when we get a case at Mayo Clinic, we operate both as a hospital autopsy service, but we also operate as the brain autopsy service for the Alzheimer's Disease Research Center, so the ADRC, the MCSA, or the Mayo Clinic Study of Aging, and also as we also do CNS autopsies on the forensic brains, so brains that have people, folks who've died in the community. So we see a spectrum of community research and autopsy brains, and this is one case that presented, I believe, through the ADRC. So our approach is generally we look at the gross findings at the time of autopsy, and then we evaluate this. We're neuropathologists. We evaluate this microscopically using H&E, and then we will employ a battery of ancillary studies using various immunohistochemical stains or special stains to evaluate the spread and severity of protein pathology. So this is just showing that we often will use tau, beta amyloid, alpha-synuclein, TDP43 as our immunohistochemical battery. And we also will include Bielszowski silver stain as our ancillary special stain. Okay, so going back to case number 1, here's the gross pathology here. And this is just the rightmost view of this brain. And I hope you can appreciate that in contrast to what we call, quote unquote, a normal brain, there is widening of the sulci and thinning of the gyri, and that would be consistent with a type of atrophy. It's really not predominant in one lobe versus the other, or different association cortexes versus the other. So I would characterize this as a mild to moderate global atrophy. On the coronal sections, we can appreciate that there is still some preservation of the precentral gyrus, and also that you can appreciate that there isn't really like the hydrocephalus ex vacuo that you would tend to see in other types of really extreme neurodegenerative disease cases, but there is atrophy of the hippocampi. When we look at the brainstem sections, and in this case, the brainstem was cut with the cerebellum, but oftentimes we'll separate them depending on the case. But here in the medulla, there really is no pathology. But what I want to point out in the pons section is that there's severe depigmentation of the locus ceruleus. So this is where we would commonly expect to see the pigmented nucleus. And then last but not least, what we also see in the midbrain is that there's moderate depigmentation of the substantia nigra. And I do want to point out that oftentimes in these cases, the depigmentation occurs where there's ventrolateral depigmentation, which is really common in a specific disease, or you can commonly see it in a specific disease. And the depigmentation of substantia nigra is not always just a complete loss of pigment. It's oftentimes this blurring or diffusion of the substantia nigra. So instead of having a really sharply demarcated substantia nigra where you can take a Sharpie and just draw a line across, it tends to be this brown sort of discoloration that's a diffuse band. And that really correlates with the microscopic findings, which we'll go into in a little bit. So on histologic findings, of course, we always start with H&E. And I remember being trained, and both Eddie and John said, whenever you look at a neurodegenerative disease case, you always start with the H&E. Don't start with special stains, start with the H&E, and you can train your eye and see the different neuropathologic hallmarks, even on H&E. And in this case, I think that's very true. So here is an H&E section of the frontal lobe. And what I want to point out here is this is the cortex, this is the neocortex. And there is some level of spongiosis, but really it's quite mild here. But what you can really see is there is a little bit of neuronal loss and gliosis, and on higher power, you can appreciate that within the neurons themselves, there are these amphiphilic to basophilic inclusions within the neurons, and it has this sort of eccentric appearance where it pushes across, the nucleus to the side. So these are few cytoplasmic inclusions that you can see in the neurons, even on H&E in the frontal lobe. And in the amygdala section, again, I just want to highlight the pronounced gliosis and neuronal loss here. And I think you can appreciate the gliosis even from this magnification, because you have this essentially this astrocytic reactive astrocytes even in the background. There's loss of the neurons here. And on higher power, you have those same basophilic to amphiphilic cytoplasmic inclusions within the neurons with concomitant gliosis, which you can point out here. Last but not least, we're going to the hippocampus, and in the hippocampus section, here's just to orient ourselves. This is the dentate gyrus, and this is the CA region. Even within on the H&E section, on the lower power, you can begin to see that there are these sort of like waxy amorphous deposits within the hippocampus itself in the CA regions. And on higher magnification, these waxy amorphous deposits are extracellular. And there's even like little nuclei involved with these extracellular plaques. It's probably microglia, a subset of astrocytes as well, reacting to these extracellular deposits. And then within the CA regions, the CA neurons itself, you can see that there are these flame-shaped nerve fibrillary tangles or intracellular tangles. Sometimes here it looks a little bit more eosinophilic, but oftentimes they'll present as a basophilic intracellular inclusion within the neurons. And also there's this concomitant, a very characteristic granulovascular degeneration that's often seen within these tau-affected neurons. And this is actually the last histologic section from here, but this is the H&E of the substantia nigra, so in the midbrain. And as you recall, the gross findings of the substantia nigra were that it was very dispersed, moderately depigmented. And what I wanted to highlight is that you have your neuromelanin-containing neurons here. I don't think the pointer is showing too well, so I apologize for that. But you have your neuromelanin-containing neurons here with these intracytoplasmic inclusions that are hypereosinophilic, very round, very pronounced, that you can even appreciate on higher magnification. The other thing that you can notice and appreciate is that there is this pigment incontinence, and there's usually macrophages or melanophages that will come up and sequester that pigment within its cell body, and that really contributes to the dispersion of the neuromelanin that you often will see grossly. So there's that gross histologic pathologic correlation there. So moving to our ancillary studies, so after we evaluated grossly and by H&E, we employ, again, a battery of different immunohistochemical stains and studies to evaluate, again, the spread and severity of proteinopathies. I think every ADRC does this slightly differently. Here we use tau, we use AT8, which captures both pretangles and nerve fibrillary tangles. We employ a beta amyloid stain, which is fairly common. Everyone uses that as well. And then we employ alpha-synuclein. We do a phospho-TDP43 antibody to look at the phosphorylated TDP. And then we also use a Bielszowski-Silver stain. So again, this approach is maybe not specific to Mayo Clinic, but it's a very common approach to evaluate the different types of neurodegenerative pathologies that can be within the community and within the research setting. So for the alpha-synuclein stain, I summarize this here in this one slide, but what you can maybe appreciate is in the frontal lobe, the amygdala, substantia nigra, and the locus coeruleus, there is this diffuse spread of Lewy bodies. So we have alpha-synuclein immunoreactive inclusions within the cell bodies. We also have significant Lewy neurites in the background. And we see that sort of pathology still within the substantia nigra and also within the locus coeruleus. So this is really capturing that, again, going back to spread and severity of neuropathology or protein pathology, this is capturing that the alpha-synuclein affects the brainstem, affects limbic regions, and affects the cortices as well. Moving now to the beta amyloid stain and looking for different types of protein pathology, this is the beta amyloid stain on the left-hand side of the frontal lobe. And on medium power, we can appreciate that there is this very frequent diffuse plaque, so much more dispersed appearing plaques. And then there are also more, I would say, cord or neuritic plaques that we can see even on higher magnification. And these cord or neuritic plaques will have tau, neuritic dystrophic tau as well within these plaques. So again, I don't want to go into all of the detail because I think Eddie really nicely covered it. And so if you get a chance, again, go back to his talk, but there's a heterogeneous array of types of beta amyloid plaques. They come in many flavors, and there's diffuse plaques, and then there's more cord or neuritic plaques. And when we evaluate the spread and severity, we're really looking at both different types of plaques. So here, this would be, I would consider this frequent diffuse plaques, as well as in cases you'll see a few more neuritic plaques too. The other pathology we can evaluate using the beta amyloid stain is cerebral amyloid angiopathy. So we do notate that in our notes, and we keep track of where we're seeing it and the severity in which we see it. The other stain that we use in conjunction, so you always have beta amyloid and you always have tau. And for us here at Mayo Clinic, we use an AT8 stain, but there are numerous different types of tau stains that can be employed in different settings. I know different institutions will use perarterial PHF1 or GT38. So here we use AT8. That's fairly common. And what I want to highlight here is within the hippocampus, especially within the CA neurons, we can see that there are neurons that have the intracellular tau tangles. So you have those that have this more dense neurofibrillary tau tangle-like pathology, but you will also have neurons that have this more dispersed appearance, much more granular within the cytoplasm, and that's more akin to pretangles. Other thing I want to highlight are these plaques that have co-pathology, both in beta amyloid and in tau, and we're basically seeing different insoluble forms of tau and soluble forms of tau. But here, even on the AT8 stain, again, you can appreciate the wide spectrum of tau pathology, both in pretangles, neurofibrillary tangles, and even neuritic plaques. To essentially corroborate that these are neurofibrillary tangles, and looking at the neuritic plaques, we employ a Bielszowski-Silver stain. And on low power, this is a temporal lobe section. And just to orient ourselves, this is the leptomeningeal surface. So this is the outer layer. And down here in the lower left-hand corner is the white matter. So this is basically full thickness of the neocortex of the temporal lobe. And even on the low power, I think you can see that there are a few neuritic cord plaques that's popping up on the Bielszowski-Silver stain. And on higher magnification, you can appreciate that those intracellular tangles that we saw in the AT8 stain are very nicely highlighted by the Bielszowski-Silver stain. So these are true neurofibrillary tangles, a form of insoluble tau. The other pathology that we pick up on the Bielszowski-Silver stain, as I mentioned, are the neuritic plaques. So you can see that there are dystrophic neuritic threads within these beta amyloid plaques. And that's something that we'll employ to stage the spread and severity of Alzheimer's disease. So just to summarize a little bit of our gross findings, our microscopic findings, and our ancillary studies, our gross pathology was that we had mild to moderate cerebral atrophy, which was quite global. It didn't seem to be affected or predominant in one lobe versus the other. There was moderate depigmentation of the substantia nigra, or you could call it substantia nigra loss. Microscopically, we saw some mild neuronal loss with concomitant gliosis, but depending on the area in the limbic structures, for example, there was much more moderate neuronal loss and gliosis. And there were also, by H&E alone, there were frequent cytoplasmic inclusions and extracellular plaques. And by the ancillary studies that we employed for tau, for example, we were able to appreciate that there were frequent neurofibrillary tangles, also pretangles. The beta amyloid, we could pick up on the diffuse plaques and some of the neuritic plaques. The alpha-synuclein stain highlighted Lewy bodies and Lewy neurites in a wide variety of the different parts of the brain. The TDP43 was absent in this case, and I didn't show that here. And the Bielszowski-Silver stain highlighted the neuritic plaques and the neurofibrillary tangles. So putting this all together, and we'll walk through this step by step. This is not just, throwing information out at there, but putting this all together, the final diagnosis looked for us a little bit like this, where we report the pure neuropathologic changes. So the top line would be Lewy body disease. Second would be Alzheimer's disease neuropathologic change. And then we often will include language evaluating cerebrovascular disease, whether there was vascular brain injury, and additional findings. And I'll show you what that integrated report looks like at the end of this. But just taking a step back to the neurodegenerative disease overview in this table again, what we're really looking at are these disease entities here. So Alzheimer's disease and Parkinson's disease dementia, or dementia with Lewy bodies. So these are, again, lesions, or these are entities that are composed of lesions that have basically amyloid or tau and alpha-synuclein. And when we look at different synucleinopathies, that's like the building block for these different neurodegenerative diseases. So it's not just Parkinson's disease with dementia or Lewy body disease that has synuclein pathology. You can see this in multiple system atrophy. They present in different ways, whether it's affecting the neurons or the glial cells, or that's really kind of how we will categorize it and diagnose it. And there's many more that I won't even go into. And for the Alzheimer's disease pathology, the building blocks or the neuropathologic hallmarks there would be the beta amyloid plaques and the hyperphosphorylated tau and neurofibrillary tangles. Just focusing now briefly on the Lewy body disease component. So this is coming from the third consensus report back in 2005. There have been a series of updated consensus reports here, but what this third consensus report put forth is basically the neuropathologic guidelines of how to evaluate Lewy body disease. So there's a few ways to think about it. So Lewy body disease is the umbrella term, and they split it up into Parkinson's disease or Lewy body disease dementias. And really the differentiation there was just a year onset of whether you had dementia within the year of Parkinson features or after a year. And that's really how we further characterize this as Parkinson's disease with dementia or dementia with Lewy bodies. The thing that the third consensus report put forth, though, was how to grade the harmonized approach to how to grade these, the Lewy body. So this is just demonstrating the scale here of mild, moderate, severe, and very severe Lewy body pathology. And if you see, essentially, again, going back to this idea that neurodegeneration, we're really just evaluating spread and severity. So this is essentially the severity scale. So looking at what we would call mild would be 1 or 2 Lewy bodies within a 10x field moving around. Moderate would be 2 or more. Severe would be 3 or more Lewy bodies with extensive Lewy neurites within the background. And then very severe would be pretty much gangbuster Lewy neurites and Lewy bodies within a 10x field. So that's just looking at the severity. Now looking at the spread, they have included this table of assignment of Lewy body type based upon the pattern of Lewy body related pathology in the brainstem, limbic, and neocortical regions. So this is a very nice table demonstrating in the leftmost column the Lewy body type pathology, and the columns show the various regions of the brain that are affected, and then the rows will dictate the different types of Lewy body pathology to call it. So for example, going through the brainstem regions, there's areas that are affected within the limbic regions and the neocortical regions. And in our case, what we had was we had the brainstem regions that were affected. So we have the cranial nerves 9 and 10 affected, or so the nuclei for 9 and 10, the locus coeruleus and substantia niger. We had, in our case, it was severely affected. So it would be at least a 3 score here. And then looking at the basal forebrain sections, we evaluate the amygdala, transentorhinal region, and the cingulate gyrus. And in our case, our pathology was very severe in these areas. And so this would probably score 4 within here. And then in the neocortical regions, the regions that are evaluated are the temporal, frontal, and parietal lobes. And in this specific case, it was essentially a 3 on the temporal lobe, a 2 in the frontal, and 2 in the parietal. So our case would nicely fit with the diffuse neocortical type. And so what that looked like in our report is that we top-lined it as Lewy body disease, diffuse neocortical type, and we included essentially like where all these areas are affected within the brain. Now moving to the Alzheimer's disease pathology, taking a step back, this is again a progressive and fatal neurodegenerative disease. It's marked by changes in memory and cognitive dysfunctions, and it can affect the language, visual, spatial, and executive domains. And it affects more than 40 million people worldwide. I think this is now closer to 50 million people worldwide. And it's the leading cause of dementia in the elderly. And again, I don't want to harp too much on this because I think that the prior talk had laid the nice, really nice foundation for the biochemical aspects and genetic aspects of Alzheimer's disease. But just to refresh our memory, again, the neuropathologic hallmarks of Alzheimer's disease are the beta amyloid plaques and the neurofibrillary tangles. So here we can appreciate, again, on H&E, you can see these extracellular plaques has a very waxy amorphous appearance. On the microscope, if you go up and down the Z-stack, you can really see the perturbations in the brain parenchyma. And just to corroborate that these are extracellular beta amyloid plaques, we obviously employ the beta amyloid stain, IHC. We can see that this is a very nice diffuse plaque here. And the other pathologic hallmark of Alzheimer's disease, as we know, is the neurofibrillary tangle, which is this intracellular tangle of insoluble hyperphosphorylated tau that can be picked up by Bielszowski-Silverstein. Again, I don't want to go into pathobiology too much, but I will just say that there are stereotyped patterns of the spread and severity of these types of pathology. So for example, in beta amyloid plaques, we have a diffuse and neuritic plaques that we'll evaluate, and that evaluation of the spread of beta amyloid is called the Thaw phase, and that was really nicely worked out by Dr. Thaw, where he had whole mount brains looking at and seeing all of them, looking at the spread and severity of that. And the different staging of it really is quite stereotyped, where it affects the neocortices first, then it moves a little bit more into the mesial temporal structures and the limbic structures, then down the brainstem, and then finally to the cerebellum. And as a note, and I know this was mentioned before, but as a note, when it reaches Thaw phase 5 or the cerebellar stage, it's usually kind of like a wispy beta amyloid stain. It's not really like as strong as you can often see in the neocortices, but this is, again, just giving you an idea of the stereotyped pattern of the beta amyloid spread in the brain during Alzheimer's disease. The Brock staging, very similar, has, this was nicely worked out by Dr. Brock, and this has a very, again, stereotyped pattern where if the mesial temporal structures and the locus coeruleus are affected and they're hit very early on, it essentially spreads out to the transentorhinal regions, and then the occipital temporal gyrus and the temporal lobes, and then it sort of moves out and to the back to involve finally the visual spatial cortex. So some of the sections that would be really important here for Brock staging, for example, would be the hippocampus and the visual cortex, because those are the two areas that kind of capture the spread and severity of the tau. And again, Brock staging is primarily for neurofibrillary tangles. So even though we sometimes include pre-tangle information, et cetera, it's really not, it's really by the neurofibrillary tangles. Okay, so again, this is hopefully a rehash of the prior, this is just kind of building on the prior talk, but looking at the NIAA criteria. And by the way, Alzheimer's disease neuropathologic criteria has gone through many iterations, starting with the Khachaturian criteria and then the Reagan criteria. But here in the NIAA criteria, which was released in 2012, this looks at just pure AD neuropathologic change as an entity. So instead of trying to assign a likelihood of whether this pathology, how this pathology explains the clinical symptomatology, essentially they sort of try to divorce that and just say this is the AD neuropathologic change. So using this AD&C criteria, we have 3 scores, and it's the A score, which looks at the spread and severity of the Thaw phase, the B score, which is the Brock stage, and then the C score, which is the CRAD. So looking at the Thaw phase, or the A score, again, looking at the spread and severity of these types of pathology, you really will have, you're really trying to capture the progression of this beta amyloid plaque. So this could be diffuse plaques, this could be neuritic plaques, but essentially it's looking at the beta amyloid plaque pathology, not CA, just plaque pathology. And the regions that are affected are the neocortices, the allocortical regions, which would be phase 2, subcortical regions like the basal ganglia, et cetera, the deep gray nuclei, for example. And then in the different phases, we the different parts of the brain, such as the brainstem or cerebellum, will then be later affected. So these different Thaw phases give rise to various A scores. So A1 encompasses phase 1 and phase 2. The A2 score encompasses phase 3, and then A3 is phase 4 and phase 5. So it's a lot of phases that I just said. But in our case, for this case, the plaque pathology extended all the way to the brainstem, but did not involve the cerebellum. So this case was listed as a Thaw phase 4, which is an A3 score. The Brock stage, in a very similar fashion, has a very distinct spread throughout the brain, starting in the transentorhinal region and the entorhinal sulcus. I think it got cut off a little bit there. But Brock stage 2 then is the hippocampus is then affected. Brock stage 3 again spreads out to the occipital temporal gyrus and the parahippocampal regions. And Brock stage 4, you should see involvement of the lower middle temporal gyri, maybe a little bit of the superior middle temporal gyri as well, and then other regions of the brain. And then Brock stage 5, this is really where you focus on the occipital lobe and the visual cortex and the peristriate regions. And this is really where Brock stage 5 and 6 become parsed or differentiated from one another. In Brock stage 5, you should have the peristriate region that it's affected, and then Brock stage 6 should be the visual cortex that's fully affected. And in our case, this really was limited to the temporal gyri and the transentorhinal regions of the hippocampus. So this was essentially staying at a Brock stage 4 or a B2 score. And last but not least, we're employing the CRAD score here. And now we're not looking so much at the spread, but we're just evaluating the severity of the neuritic plaque pathology within the brain. And so the neuritic pathology would be scored as either C1, C2, or C3, or sparse, moderate, or frequent. And you can evaluate this either by a thioflavin stain, or you can evaluate this by a Bielszowski silver stain, or you can pair beta amyloid and tau stains together and kind of derive a neuritic plaque score from that. Here again, we employ the Bielszowski silver stain, so that's what we use to grade to employ the CRAD score. And in our case, they had severe or frequent plaques, and that was given a C score. So just going back to this table here that combines the ABC score, it's saying score a lot. For the A or the Thal phase, we are in Thal phase 3. The Brock stage, however, was limited to essentially the mesial temporal structures. So that was a Brock stage 4 and B2 score. And then last but not least, the CRAD, looking at the neuritic plaques, was severe. So that would be intermediate ADNC, so intermediate Alzheimer's disease neuropathologic change. So what that looked like in our report is essentially we report out the ABC score, and then we give the intermediate likelihood designation, again, just coming from the NIAA criteria. And we actually have a table that lists out every single area where we evaluated for neuritic plaques and then diffuse plaques. And also we fill out every single area for neurofibrillary tangles looking at the Brock stage. So the one thing I want to do, I would like to just touch upon very briefly, is looking at the additional findings. So it's not just protein pathology that underlies neurodegenerative conditions. It's also cerebral vascular disease or different types of vascular dementia. And that's why we do incorporate evaluation of cerebral amyloid angiopathy. And we also will look at different things too, and we'll see it in subsequent cases. But we do report out the cerebral vascular disease and whether there was vascular brain injury. So for the final diagnosis in this case, again, this is something we saw before, but now layering all the different neuropathologic findings and going through the harmonized criteria, this would be top-lined as a Lewy body disease, a diffuse neocortical type. The Alzheimer's disease neuropathologic change, or ADNC, we gave it an ABC score. So this would be A3, B2, C3, which is an intermediate likelihood. And then in terms of cerebral vascular disease, there was a mild to focally moderate perivascular tissue rarefaction. There was no atherosclerosis in the circle of Willis, and there were no vascular brain injuries. So the key points in this first case is that it's just to review like very broad pathology, looking at common neurodegenerative pathologies like ADNC criteria and also Lewy body probability scores. Moving to the second case, this is a 74-year-old male who died with an at least 7-year history of REM sleep disturbance with neurocognitive decline. The pertinent family history includes a mother and an aunt who both had dementia, and this REM sleep disorder was first noticed and characterized by dream enactment and jumping out of bed that resulted in injury. He was later noted to have a mild motor symptoms with autonomic symptoms and demonstrated signs of non-amnestic cognitive impairment, but was overall high functioning. He later showed progressive decline in ambulation, increased stiffness, weight loss, decreased speech, and urinary incontinence. So looking at the gross pathology here, and these are very nicely taken by our autopsy techs. I see a lot of questions popping up. I wonder if maybe I'll save it for the end, but I'll make sure there's time for questions at the very end. Absolutely. So just evaluating for the gross pathology here, this is the left hemisphere, the left view of the cerebral hemispheres. There is mild atrophy. Again, there's widening of the cell size, slight thinning of the gyri that you can really pick up and appreciate, but I think it's not as pronounced as the last case. It's quite subtle, I would say. On the coronal sections, what we can appreciate is that you can even see more of this widening of the cell side here and thinning of the gyri. There is a little bit of thinning of the white matter structures, but I do want to point out there's almost like flattening of the caudate head, here. And when we move more posteriorly to look at the brainstem, we can see that there is substantial nigral loss. There's also depigmentation of the locus ceruleus, and there's a little bit of depigmentation within the hypoglossal nucleus. So again, just going through our approach, looking at the H&E first, what we saw in the frontal lobe is actually a much more moderate or mild to moderate spongiotic change compared to the last case, where we have this rarefaction of the parenchyma. It's a little bit more holy, not prayerful, but just a little bit more holy. And you can see this rarefaction here. And there's, even on higher power, there's concomitant gliosis that you can point out within, that you can see by the reactive astrocytes within the superficial neocortical layers. When you go to the temporal lobe, however, there's this pronounced thinning of the temporal cortices. And this is, again, in contrast to even the frontal lobe. But within the temporal lobe, you can see that there's this thinning of the white matter structures. And there's also this superficial spongiotic change within the neocortical regions. So here you have much more moderate to severe neuronal loss and gliosis. And again, you can see that on the higher magnification of this extensively rarefied, almost ratty looking, holy looking parenchyma with concomitant gliosis. And even on H&E, what I want to point out is in the midbrain sections, we again have this loss of the nigra. And on higher magnification, and especially within the ventrolateral surface, but on higher magnification, we can appreciate that there are these cytoplasmic inclusions within the nigral neurons, and actually two excellent examples of that. And there's also this sort of concomitant gliosis that has these melanophages coming out, taking up that pigment incontinence, and then sort of creating that diffuse nigral appearance grossly. So whenever I see this type of like frontal temporal, I would say, degeneration, especially on the coronal surface, and it's really just affecting the frontal and temporal lobes, I immediately think of different types of frontal temporal lobar degenerative conditions or underlying pathologies. And one of that would be looking at the TDP43. And again, we'll go through some of the approach later, but looking at the TDP43 pathology in this case, we can see that in the frontal lobe sections, there is TDP43 deposits and inclusions limited to the superficial layers of the neocortex within the frontal lobe. And then within the gray matter on higher magnification, you have essentially these neuronal cytoplasmic inclusions, these little short dystrophic neurites, again, limited to the superficial surfaces. And then within the temporal lobe, very similar pathology, limited to the gray matter, superficial gray matter. And in the white matter, we had a few of these oligodendroglial curvilinear inclusions here. Looking at now the alpha-synuclein pathology, because again, that's something that we picked up on by H&E, within the frontal lobe, very similar to the last case, within the frontal lobe, we have the Lewy body, or the alpha-synuclein immunoreactive inclusions within the neurons themselves. And then we also have extensive Lewy neurites within the background, and it affected the frontal lobe, the amygdala, substantia nigra, and locus ceruleus, again, highlighting and underscoring the spread and severity of alpha-synuclein pathology. So just to summarize what we saw in this second case, gross findings, there was this sort of mild generalized atrophy looking at it on the external surface, but when we cut through it, we noted that there was severe hydrocephalus ex vacuo, there was significant atrophy of the temporal lobe, and some atrophy of the frontal lobe as well. There was also marked depigmentation of the substantia nigra. Microscopically, we appreciated moderate superficial spongiosis that was predominantly involving the temporal lobes over the frontal lobes and other neocortices. And then in terms of the ancillary studies, we saw that there were alpha-synuclein immunoreactive inclusions, as well as TDP43 pathology. And so integrating all that leads to the neuropathologic diagnosis of frontal temporal lobar dementia with TDP43 inclusions, or FTLD-TDP. The second pathology that we saw here was Lewy body disease. And then again, we always comment on cerebral vascular disease and vascular brain injury, et cetera. And going back to this table, we looked at Alzheimer's disease and Parkinson's disease pathology, or Lewy body dementia pathologies, but those are fairly common. You'll really see that in not just the research setting, but you'll see that in the community setting, not infrequently. And I would say the incidence of these types of pathology occurring together is actually pretty high. In the UPenn Brain Bank, in a study published many years ago, they found that there was a lot of pure AD pathology was maybe like 30% of the time. The rest of the time, those cases had concomitant alpha-synuclein pathology or TDP pathology, et cetera, et cetera. So the first case was just an example of super bread and butter common cases. This case here is highlighting basically a different type of neurodegenerative disease where we're looking at frontal temporal lobar dementias. And these FTLD-opathies, they have different types of underlying pathologies, either tau or TDP, et cetera, but the lesions themselves are really characterized by neuronal and glial pathologies or inclusions, or cytoplasmic and nuclear inclusions. And the driving pathologic neuropathology there are different types of protein pathologies. So I do want to take a step back and just very briefly differentiate FTD from FTLD. So FTD is really looking at the clinical subtype, and those clinical subtypes present very differently. They can present with changes in their behavior. So the behavioral variant FTD, BVFTD is one thing, or they can present with changes in their language. And those are primary progressive aphasias. And the subset of that is primary non-fluent aphasia, semantic dementia, et cetera, et cetera. So there's a separate clinical presentation of these FTDs. When we're talking about the pathologic subtype, that is FTLD, just to make it a little bit more confusing, but that's FTLD, frontotemporal lobar degeneration. And those subtypes are essentially diagnosed and characterized by the different types of protein pathology, as I mentioned earlier. So there's sometimes underlying tau pathology, there can be underlying TDP pathology, or there can be underlying FUS pathology or other types of pathology. That's sort of beyond the scope of this talk. But very briefly, the different pathologic subtypes of FTLD tau is progressive supranuclear palsy, cortical basal degeneration, Pick's disease, et cetera. And the underlying pathology or the subtypes for FTLD-TDP are the subtypes A through E, which we'll go into in a second. So I want to differentiate these two things because they're not always one-to-one. You don't always see behavioral variant shows this, semantic variant will show this. There are strong correlations there, but I do have to divorce the clinical symptomatology from the pathologic subtypes here. So just focusing in on the FTLD-TDP 43opathies, this was a very nice review, or this was a very nice paper published by Eddie's group back in 2017. I like this a lot. I think the schematic is a really intuitive way of looking at the different type of FTLD-opathies for TDP-opathies. And what this marries is looking at the cortical pathology, seeing the distribution of the TDP43 pathology, whether it affects the different regions of the superficial layers or whether it affects the white matter, et cetera. And then looking at the common phenotypes, the clinical presentation, and then evaluating the various genetic associations here. So for the FTLD-TDP types, there's types A through E. Again, as I mentioned, the TDP will affect different parts of the white matter and different parts of the neocortex. So for example, in type A, the TDP pathology manifests as neuronal cytoplasmic inclusions or short dystrophic neurites. It's fairly limited to the superficial surface. But in type B, in contrast, it's neuronal cytoplasmic inclusions that really affects the full thickness of the cortex. And there's generally white matter pathology in both of those subtypes. These two, I would say, maybe these three are the most common FTLD-TDP subtypes that we'll frequently encounter, quote unquote, in the wild or even in the brain bank as well. And what that really looks like, again, is you have these neuronal cytoplasmic inclusions in type A, these short dystrophic neurites. And then in type B, you have essentially just these neuronal cytoplasmic inclusions. Type C are much more of these long dystrophic neurites. And type D are predominantly just intranuclear cytoplasmic inclusions. It almost looks like cat eyes. I liken it more to like Sauron's eye from Lord of the Rings, but it has this really lentiform, really distinct lentiform appearance. And then type E is much more granular and very, has a lot of different types of like granular fuzzy neuronal cytoplasmic inclusions. So that's just an overview of the different FTLD-TDP subtypes. Again, going to our case, what I wanted to highlight is in our case, when we looked at the frontal and temporal lobes and the other different neocortical regions, the pathology was really only limited to the superficial surface. So really the superficial surface, there was no underlying deep cortical layer pathology, and there was white matter pathology. So this, in our case, it was more in keeping with type A. Again, just the Lewy body disease types, because again, in that case, we had alpha-synuclein pathology that covered really just was throughout throughout the brainstem, the limbic region, and the neocortical region. So that would be classified as diffuse neocortical Lewy body disease. So the way this report looked like ultimately was we called this a frontal temporal dementia with TDP inclusions, and most consistent with type A. And we do know that the decedent had a granular mutation. So it is in keeping with that table that was shown earlier, is that there are strong genetic associations with these different FTLD-TDP subtypes. The other second diagnosis, there's a misnumbering there, I apologize for that, is that there was Lewy body disease and it was a diffuse neocortical type. What I wanted to highlight here is it's not uncommon to have these sort of co-pathologies. When I first came here, I thought it was really unusual to have Lewy body disease with a granulin mutation or FTLD-TDP 43opathy. But when you look in the literature, there's some association between this alpha-synuclein pathology and a granulin mutation. And even here in our brain bank, there are a few cases that show that have type A TDP, FTLD-TDP, and they also have alpha-synuclein pathology. So just goes to show you that you can learn about these different distinct neurodegenerative entities, but you may see them in practice, you may see them co-occurring. Okay, so the key points here was just to review FTLD-TDP as a neuropathologic entity. And in the remaining time, I'll just look at this. This is the last case here in terms of practical case approaches. But this is a 73-year-old female. She presented with this feeling of being absent-minded or disconnected. Her memory or amnestic test, Kochman's short test, was unrevealing. It was 36 out of 38. Her MRI was within normal limits. However, within the following year, she began to develop personality changes, such as obsessive and compulsive behaviors, a predilection for sweet foods, showed little verbal output, and was disoriented to time and place. Physical exam showed marked bradykinesia, slow eye movements, and that becomes really important later on. But she did have an intact vertical and horizontal gaze, a slowed and unsteady gait, and mild rigidity. The FDG PET here showed severe frontal hypometabolism, most marked in the right superior frontal region. And near the end of her life, she was essentially non-communicative. She had no verbal output. So looking at her gross pathology again, because I really wanted this kind of like part 2 neurodegeneration to be case-based, but looking at gross pathology. So evaluating this here, we can really appreciate that there is really maybe mild cerebral atrophy here, not that bad truly. There are various defects within the temporal lobe themselves. And when we look at the coronal sections, here again, there is like not too much gyral thinning or widening of the saw site compared to the second case. And here, the anterior commissure looks like it's nicely intact. There is, however, a little bit of this coloration of the caudate head and flattening of the caudate head. And the subthalamic nucleus is not the most healthy, I would say. And the other thing we'll evaluate is whether there's dilation of the temporal horns. And here, I think there's maybe mild to moderate hydrocephalus ex vacuo. Looking at the hindbrain or looking at the brainstem, there is relative preservation of the substantia nigra here, and there's a little bit of depigmentation of the locus ceruleus. But I think a lot of the pathology, primarily that we saw in H&E, was truly limited to the deep gray structures in the cortex. So for example, on H&E sections, in contrast to the last case, the frontal lobe still had preservation of the neocortices. The white matter looked a little bit ratty or rarefied. There is mild superficial spongiosis here with concomitant gliosis, and the temporal lobe also looked, I think it was like relatively preserved when you even compare it to the frontal lobe section. So you don't have that same level of neuronal loss or gliosis within the temporal lobes. But within the amygdala, what we did note was that there were these very large, almost like swollen profiles that you could even pick up on the H&E, and there were also ones where it was much more akin to ballooned neurons. So there are ones with basically neurons that have this really balloon type of cytoplasm that we saw both in the amygdala and within the anterior cingulate. And within the substantia nigra, there was gliosis here with a little bit of depigmentation. And now moving towards just in the interest of time, I'll move towards the special stains that we employed. In the neocortex, there was a lot of tau. So there was no beta amyloid, but there was, however, a lot of tau. And even on the tau sections, you can appreciate that on medium power, instead of having this really distinct neurofibrillary tau tangles that you commonly see in Alzheimer's disease, the tau pathology was relatively limited to the glia. So here within the glial sections, in the astrocytic section or astrocytic cells, you can appreciate that there was this more distal sort of tau pathology that's forming these plaques. It's probably much more pronounced on the 4R tau, which is a type of isoform stain that we use to look at the different types of tau isoforms, such as 3R or 4R. We commonly don't use 3R or 4R up front. We'll, again, just use the AT8. But if there is a question of needing to further subtype the tau isoforms, we will use this selectively. And on the 4R tau stain, we can appreciate that these astrocytic plaques are much more pronounced, meaning that the tau pathology has these very almost like thick quality, and it's much more distally located in the cell. 3R was completely negative, and in the white matter, we had these oligodendroglial inclusions. In the substantia nigra, we still had a few of these globose tangles, so these very large types of tangles that look like globes within the cytoplasm of the neurons, and we even had a few neurites within the background. And again, this was highlighted by the 4R tau and not by the 3R tau. So what this is telling us is that this is a tauopathy that's really characterized only as a 4R isoform tau and not a 3R. Within the amygdala, there was a little bit of TDP pathology. And I think I saw Dr. Kenyon's question of how often do you employ FTLD or TDP stains? We will commonly do this. We'll employ it on the amygdala, hippocampus, and the frontal lobe to evaluate for late. Just in the interest of time, I don't think we have enough time to go through this, but I do want to highlight that this was an FTLD tauopathy that was consistent with cortical basal degeneration. And there was another entity here called limbic predominant age-related TDP 43 encephalopathy neuropathologic change. So there was a level of late NC here as co-pathology. Just to go through very briefly the pathologic subtypes for FTLD tau. As I mentioned earlier, there's progressive supranuclear palsy, cortical basal degeneration, Pick's disease, FTDP17, tau, like all sorts of stuff that I don't think that's beyond the scope of this talk, but these are some of the common presentations for the FTLD tau. And in this case, it was cortical basal degeneration, which is differentiated from cortical basal syndrome. They present with motor features, gait abnormalities, alien limb phenomenon. One of the big presentations, however, is apraxia or language disturbances. And that's something that we did see in our patient's case. Some of the pathology is really, this was nicely laid out by Dr. Dixon in 2002, but the pathology is really limited to this sort of astrocytic plaque and balloon neurons that affect different parts of the brain. In cortical basal degeneration, this is a chart that goes through the different areas of the brains that are affected. You can really see it in the cerebral cortices and the subcortical regions and in the brainstem, but it has a very, very characteristic tau pathology. And just one way to think about tauopathies is that you can look at them as different isoforms. There's this one way to look at it is looking at it as a 3R or 4R tauopathy. And this kind of hierarchy is just to show you that there are various 4R tauopathies, and the cortical basal degeneration would sit within a pure 4R tauopathy, as well as progressive supranuclear palsy, et cetera, et cetera. Some of the more mixed pathologies would be like Alzheimer's disease or CTE, et cetera. But just focusing now on the much more common 4R tauopathies, they have a very distinct tau morphology, such as tufted astrocytes that you can see here, and that's more characteristic of progressive supranuclear palsy, astrocytic plaques and cortical basal degeneration, and Pick bodies. Unfortunately, I think I'm running out of time, but I just 2 minutes, just want to go through gross pathology of PSP because I think it's really nicely shown here that you have somewhat thinning of the tectum, and then you also have this severe depigmentation of the subthalamic nucleus, and it really affects the hindbrain or the brainstem. And this was a case of Pick's disease that we recently had, which is just very nicely showing this sharp demarcation with the circumscribed lobar atrophy of the frontal lobes, sparing the precentral and postcentral gyrus. I think I'll end here. This is a little bit about late NC, but just in the interest of time, I'll end with that. But let me just put the question and answers up. I will highly encourage everyone, though, to, if they're interested, to also check out Eddie's talk, which goes through, I think, some of the more biochemical structures of these entities. So with that, I thank you for your time, and sorry for going a little bit over. I'm happy to take a few questions.
Thank you, Aivi. There are, as you noted, this was wonderful, a couple of questions in the chat. So if you think you can answer maybe one or two of them, given that we have limited time, please go for it.
Oh, absolutely. So I think just in order of how it's come in, thanks so much for including Eddie Lee's talk. From Dr. Lopez, could you please explain the reasons some ADRCs utilize the presence of tau expression in neurotic plaques for the final diagnosis of the ABC score? Okay, so this is basically the ABC score, as I mentioned, is looking at spread and severity of diffuse plaques and neurotic plaques. And neurotic plaques, as we know, are comprised of beta amyloid and of dystrophic neurotic tau. So that's why some places may not always employ thioflavin or Bielszowski. They'll employ both beta amyloid and the tau to look just specifically for neurotic tau. And that would make up the C score of the ABC score. And as Dr. Kenyon asked, do we routinely do TDP-43 stains on dementia cases? Yes, we do. If our, depending on our threshold for, or index of suspicion, just in general for older folks, we will employ TDP to look at the amygdala, the frontal lobe, and the hippocampus, because we're looking for late NC. And that really captures basically stage 1, stage 2, stage 3. But if we're really concerned for FTLD-TDP, like there's frontal temporal degeneration, we will take sections beyond, we'll stain for sections beyond that, and we correlate very, very closely with gross pathology, just to ensure that, you know, we're not missing anything else. Why do you think that we're seeing overlap of these neurodegenerative pathologies in the same patient's breed? I think, truthfully, it's a great question. I think aging has a lot to do with it. The older you get, the more the likelihood you're going to get hit by something. But the other component here is there could be underlying genetic associations. As I mentioned in that granulin FTLD case, we saw that there was a diffuse Lewy body disease pathology, and lo and behold, there is actually a very strong association with granulin mutations and alpha-synuclein pathology, irrespective of the TDP. So I think it's just something to do with aging. It's multifactorial, but there's likely a genetic underlying factor in certain cases. How do I differentiate between AGD from CBD in cases that have astrocytic plaques? This is really tough. In the last case, I actually did have a gyrophilic grain disease because there's so many overlapping features of ballooned neurons in different regions of the limbic area, and then also these astrocytic plaques. However, the astrocytic plaques are in this case, they were quite pronounced, especially on 4-hour tauopathies. AGD, or gyrophilic grain disease, as you know, is another 4-hour tauopathy, but I look for more of those punctate grains that you would see that's much more uniform. To be fair, though, this case, because the distinction was super difficult, I did ask Dennis Dixon to take a look at the case too, just to see if they're truly different or whether they exist on a spectrum or they're two separate entities. I think that remains to be, I think there are two separate things, but I think the pathologies can overlap. And thank you so much. I think I'm ending on time. So
yeah, that was excellent. Thank you. You were able to get all the questions asked.
I appreciate everyone's attention. So enjoy everyone's lunch.
Thank you. Thank you for an excellent presentation. Thanks for joining today. We would ask that you take just a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. And this concludes our session for today. Thanks again.
Thank you.